getting to interact with you all, trying to bridge that gap between civilian and Army medicine, right? So without further ado, just moving right along into our airway management and a combat casualty situation. You see here tactical combat casualty care. All right, next slide. The first thing you need to establish is when you are in a tactical field care environment and you have the opportunity to be able to perform a airway management, first you got to determine whether or not that patient is conscious, right? So you're going to go ahead, you're going to approach your casualty, whether it's in a combat scenario or in a civilian scenario. Let's say you see someone that fell off of a ladder, and you see that they're just on the ground, they're next to a ladder, stuff like that, and they're unconscious. You approach that person, you say, hey, you okay, you all right? You want to try to establish whether or not they're alert or conscious, right? If they don't respond, then we're going to move right along into assessing that airway. Okay, next slide, please. Today we're going to be covering three different types of airway. Okay, we're gonna discuss the NPA, nasopharyngeal airway. We're going to discuss the King LT, and we're also going to discuss the cricotomy, okay, process. So yeah, we'll go into that here in a little bit. So during World War II, you see Vietnam estimated about 1% loss due to unsecured airway. We personally believe that's a gross underestimation. Okay, a snapshot study says really more about 11% of deaths could have been prevented if they would have been able to establish an appropriate airway. All right, so next slide. This is about 42 slide presentation, and some of it doesn't apply. The main thing I want you all to understand is how to determine what the necessity is for a specific type of airway and what the contraindications are for that type of airway as well, right? So we're gonna move right along into a lot of the slides so that we can go straight into the hands-on portion, which is real interesting. Okay. So during your evaluation, you're gonna look, listen, and feel. You're gonna approach that casualty. You're gonna say, hey, you okay? You all right? If they don't respond, are they speaking to you and able to control any secretions? Okay. You see here, if they have a gag reflex, if it's not reliable, then you go ahead and you could work from there, right? Other than that, my apologies. Turn this phone on. Other than that, so you approach the casualty, you say, hey, okay, you all right? Are they alert? If they don't respond, then you determine, that means that they're not alert, they're not verbal, right? They may be unconscious. Basically, you come up to the casualty. If you see if they have any specific head injuries, okay? You're gonna see, for example, we have this acronym, it's called DCAP BLS, okay? That's for deformities, contusions, abrasions, lacerations, and swelling. You observe for DCAP BLS, if you don't see that there's any, that there are any fractures or head injuries on the skull, maxillofacial area, then what you're gonna do at that point is then you're going to palpate for what we call TIC, which is tenderness, instability, and crepitus, right? So you observe for DCAP BLS, and then if you don't see anything, then you can palpate for tenderness, instability, and crepitus of that maxillofacial area. And then knowing that they don't have that maxillofacial trauma, then you can establish two different types of airway, okay? That could be either the nasopharyngeal airway, or it's going to be the King LT, which is through the mouth, okay? Those are when somebody does not have any maxillofacial trauma, established airways that need to be done, okay? If we're gonna get into it later on here as well, if they do have facial trauma, who can tell me about another reason why you would not insert a nasopharyngeal airway or a King LT in the mouth? What would be another reason, another injury that the person may have on their face that you would not be able to insert one of those airways?
They broke their nose.
Mm-hmm.
Like a broken trachea, like the actual like airway is broken.
Okay, yeah, part of the airway, you know, that would be like a bad day, because that might even affect the cric a little bit, depending if the trachea is damage, right?
Right.
But we're talking about a little more like from the chin up, you know, from the chin up. So basically, it's burns to the face. Okay, so so if somebody's got maxillofacial trauma and burns to the face, automatically you know that you would have to not do your nasopharyngeal airway or King LT, and at that point you'll be going on to your crike, which we'll get into here in a little bit. Okay. You see here they're asking about whether or not there are blood or debris in the mouth. And when you come up to that casualty, you open the mouth. They didn't respond to you. You open the mouth, see if there's any blood or foreign objects, tobacco, gum, dentures, etc. Is the face symmetric? If not, facial fracture until proven otherwise, right? You see somebody, you know, may have some type of facial trauma, then you already know, keep that in back of your mind that there's a possibility you may have to crike that patient versus an NPA or King LT, okay? Is there a crepitus movement? We talked about that. Look at the neck, watch for expanding hematomas, right? Next slide. Next slide. Next slide. Okay, as you can see here, positioning of the patient is key, right? So for example, this right here is a patient who has facial trauma, and at that point, let's say you don't have an immediate airway, NPA, or a King LT, at that point, it's just a matter of positioning the patient into a position of comfort, right? So in this point, you can see that they're just sitting up, you know, trying to keep anything from pooling up into the lung area, especially if they would be unconscious, right? Now this right here, we call this the lateral recumbent position, the way in which you see them here. They also call this the drunken buddy position. What you want to do is, when you're in a scenario, we actually had, on a serious note, we had a soldier who got to his unit. You know, he was very young, not even 21 years old yet, and started drinking a lot, you know, when he went to sleep, they didn't, nobody turned him to his side like this. So he was so drunk that he vomited, and the vomit went into his lungs. He drowned in his own vomit. You understand? So this is a very good position to either, when somebody's unconscious and you don't have an immediate airway with you right away, or they're just somebody that's real drunk, you might want to put them in this lateral recumbent position here. And we actually one up this position right here by tucking this leg behind the knee here. So this, with the hand here under, you see the right hand here under the face, and this leg tucked behind that knee, it'll cause that person, lateral recumbent position, to not roll over. And then at least, you know, worst case scenario, that person vomits, or all of a sudden they become conscious, it'll naturally, the fluid will move off to the side. It won't just, you know, go into their lungs and cause them to asphyxiate via lungs, right? Next slide, please. Okay, can you perform a head tilt chin lift, right? That's what we talked about when you have your patient laying on the ground, you lay at their side, and then you're gonna basically place your fingers under the chin and tilt the head backward, assuming that they don't have any head trauma, right? No head trauma. Then you can do the head tilt chin lift. It'll cause for that airway, the minute you tilt the head backward, it'll cause for the airway to lengthen out a little bit more, and then it'll provide for a better airway management, okay? When we talk about BVMs here, they're talking about the bag valve mask, which I have on hand. I'll show it to you here in a little bit. We have the one hand and the two hand method, depending on the type of assistance that you have, right? So one hand is gonna be what we call an ENC clamp on the mask that goes over the face, and the other one on the bag itself. Two hands is sometimes when somebody else is assisting you to hold one of the either the King LT or one of the respiratory management airways, and the other person is just using two hands to blow that air into the lung cavity once the airway has been established. Okay, next slide. Okay, so here, this is regarding, you know, like suction. This is a little more advanced. We don't have a suction kit here, but that's a sample of one of the suction kits that the Army has. Every so often, they do a suction of fluids. If they're not turned on to the side on lateral recumbent, there'll be an intermediate suction every so often, between the, airway management. Okay, next slide. Who's seen one of these before? Okay, have you ever had one inserted into your, nasal cavity?
No, I watched
No,
it being
neither.
inserted.
Say that again?
I've watched it being inserted.
You watched it be inserted? Yeah, it's a little bit of an uncomfortable procedure. Would anybody like to volunteer to have one done?
No.
Okay. All right, so we'll keep going into that. I was actually hoping for somebody to want to volunteer, but we'll get into that here in a little bit. So it's an airway adjunct, okay? It says, basically, you know, yeah, it is a little bit uncomfortable, but at the end of the day, what you want to do is, during a trauma assessment, for example, what we do in the Army, one of the best things we have to establish after we obtain hemorrhage control, the other thing we're worried about is, you know, hypoxia, you're right, low oxygen levels in the blood and not enough oxygen levels getting to the brain. And who can tell me how many minutes the brain can be without oxygen before it starts to get brain damage? Okay, she said 2 minutes, she said 3 minutes.
3.
You said 3 minutes as well? All right, there may be, you know, little differences. Always go by the SOP of your, whatever place you're gonna be assigned to and everything, but worst case scenario, definitely after 6 minutes, that person is gonna have some brain damage if they're without oxygen, without for that long, okay, for 6 minutes. One thing that you should always try to do, and we're gonna get into it when we do the airway management, is as you're administering that airway adjunct or whatever you're gonna use to establish the airway, hold your breath while you're doing it, and you'll see that that's how long that person is also without oxygen. It'll make you have a sense of urgency. If you don't have a sense of urgency already, and they're hurting for oxygen, and you're holding your breath, you know just how bad you need to establish that airway for them so you could breathe for them with that back valve mask if you need to, right? So next slide. That's all right. All right, this is the King LT. We're gonna get into this one in more detail. As you can see, it's got a valve here, which you connect a 60 cc syringe to, and then you check it prior to inflation. We'll go into that when we do more of the hands-on, but this is more so that you can all see at once. There's two balloons. We got the distal and the proximal cuff. Basically, you check to make sure that those can inflate prior to doing the procedure itself. If your equipment's not good, then you're going to be wondering why the process isn't working. Did you insert it too far in, or did you not? You know, you got to establish that definitive airway. And there's some valves here. All this bolt does right here, the proximal cuff, is it inflates around the tracheal area or windpipe, so that now this other shaft right here can provide for air access into the lungs. Okay, so we'll go into how that's inserted. This x-ray line right here, and then on top of that you see this is the portion, doesn't indicate it there, but that's the portion where the bag valve is going to be connected to the ambu bag, and then you can go ahead and start ventilating that patient. Okay, so next slide. And that's a picture there of, you see how what I was describing, the way it sets anatomically, it makes it to where even if that patient were to have an allergic reaction and have a constriction of the airway, that person is still, because the King LT is in place, is going to maintain it open, that airway is going to be managed, and then now you're going to be able to perform your intervention and make sure that that person is getting positive perfusion, right? So next slide, please. Talking about the King LT, the indications, it shows you right here: emergency intubation, single use of supraglottic device, which is the King LT. It can be used for positive pressure or spontaneous ventilation. Okay. One of the main things you really need to remember here is that the person, most people have a gag reflex. If a patient can actually take a King LT and have it lodged in the position in which you saw in the previous slide, that tells you right there that that person is most likely 95% of the time they're going to be unconscious, because a conscious person will have a normal gag reflex and will not be able to take that King LT as you saw within the previous slide, right? Next slide, please. Next slide. Okay, complications, right? So you've got, we're gonna talk about, complications here once I have the, definitive airway established with the King LT. Basically, let's say, your patient, becomes conscious all of a sudden. The minute they become conscious and that airway is lodged in place, they're gonna wanna vomit. Immediately, you would have to retract the air from the bowl and then, pull it out and have them turn to the side so they could vomit. You understand? Because that's gonna have, the minute they come unconscious and they feel that obstruction in their airway, they're gonna feel very uncomfortable. They may vomit. Some of the vomit may aspirate into the lungs if you don't work fast to do that, right? So you gotta watch out. That's why you continue to assess your patient at all times, right? Check them out, see what they're doing. Normally, by this point, you'll also have a pulse ox on their finger, right? Who can tell me what interferes with pulse ox reading positive O2 gases in the blood?
Nail polish?
Nail polish, perfect, yes. Is that what you were gonna say too? All right, good job. All right, next slide. Okay, contraindications here, responsive patient with a gag reflex, we talked about, right? Any disruption in the anatomy that won't allow for an adequate cuff seal, you know? Other than that, usually when they talk about that, they're mainly discussing an obese person or somebody with a musculoskeletal malformation or kyphosis. Sometimes their airway is a little more difficult to manage, okay? Caution of ingestion of caustic substances, right? If somebody, you know that somebody tried to commit suicide or something, has some type of caustic substance, then you gotta watch out whether or not you would wanna try to use the King LT at that time, right? Next slide. And these are the different sizes, so when you open up one of your King LTs, you're gonna see that they have different sizes depending on the height of the patient. So it's got a little cheat sheet chart on there that lets you know, but the average adult will be anywhere from 5 to 6 feet, and we normally use the red one for that, okay? Next slide. And here it is what I was just discussing a little earlier. Okay, so 5 to 6 feet tall, you usually use the number 4, red, that's about pretty standard for most people. Okay, next slide. Okay, it talks about where the passage is, we spoke about that earlier. Next slide. Again, rather than getting in too much detail into each specific slide, I wanna make sure that you get enough hands-on practice, and that's why we're gonna move through one of these and only go through most of the mainly relevant stuff. Okay, next slide. Okay, this one talks to you about the insertion of the actual King LT and what the required depth is. Okay, so you see here, when they talk about hub to the teeth, they're talking about part of the bevel on the King LT, the top red top. We'll go into that a little more detail here in a little bit. Inflate and then pull back slightly. It says, you may have a little bit of resistance. It says here, recent autopsy evidence showed 4 out of 7 were placed incorrectly, 2 anterior and not hub to the teeth. So what's gonna happen is if you don't insert the King LT enough, it's not gonna penetrate specifically to the area in which it needs to keep the trachea open. And then when the balloon inflates, it won't properly manage and go into the lungs as it should be. Okay, another complication could be if you turn the King LT too much. There's a possibility that what's going to happen is two things. If you go too far into the lungs, it might naturally bifurcate into the right side, and then now you're only inflating one lung versus providing air to 2. So you inserted it too deep. Okay. The other complication can be that when you insert that King LT, there's a possibility that it may go into the esophagus versus any of the trachea. So what's going to happen is now you're going to be inflating the stomach instead, and you would see that in your patient the minute you start compressing that the ambu bag. You will see that the patient's belly starts distending, right? And that's another reason why I brought a stethoscope today, so that you'll be able to auscultate on the stomach region and see, or you'll auscultate the lungs, and then of course what you don't want to hear is an auscultation of air going into the stomach because you inserted your King LT improperly, okay? Next slide. Actually, go back one, please. You see here, post-intubation confirmation is what they were talking about. You're looking for, a little fog in the tube, some breath sounds, because as soon as you do your insertion, you would lean over to look, listen, and feel, right? So anytime you're assessing your airway, basically the patient is laying to the side. I did my no facial trauma, right? No maxillofacial trauma. I tilt a head tilt chin lift. My airway's a little more patent. I'm looking at the chest for equal rise and fall of the chest. And I'm also listening for any gurgling sounds because it can indicate what? Gurgling sounds? Right, fluids, right? Some kind of blood or fluids in the lungs, right? So, especially in like a trauma type scenario, stuff like that, you don't know if they have a gunshot or whatever, they have some type of blood in the lungs, right? So you're listening for the gurgling, you're looking for equal rise and fall of the chest, and then on top of that you're seeing if they're breathing, you're gonna feel on your face whether or not that person is breathing or not, right? Same thing, after you insert your immediate airway, you're gonna do the same thing. Look, listen, and feel, assess, make sure that your airway was placed properly. Okay, next slide. You see here a couple pictures about how it looks when it's inserted correctly and when it is not inserted correctly. Okay. All right, next slide. Next, this one is going to be about when we go into the cric. Okay, so the cricothyroidotomy, there are many places where you're going to see two different types of spellings. They go interchangeably. Sometimes it will not have the I in there, sometimes it will. Okay, it depends what text you're looking at, but you'll see both of them on there at some point. Okay, an emergency surgical procedure where an incision is made through the skin and cricothyroid membrane, which allows for the placement of an endotracheal tube into the trachea when the airway control is not possible by other methods, right? So you came up to that casualty, whether it's civilian or a trauma scenario, maybe it was somebody that was involved in an active shooter incident, you know what I mean, at an office building or something like that. You find somebody that's got some kind of like gunshot trauma to the face that fortunately missed the brain area. Now there's facial trauma, maxillofacial trauma, maybe some cranial trauma, or maybe they were involved in a motor vehicle accident which caught on fire, and then now this person's still alive, but that fire has caused for part of the face to kind of like be like melted. So you need to, at that point, then you're going to have to go to your cricothyroidotomy process, right? So next slide, please. Okay, indications talking about pretty much what I just mentioned here. It just tells you inability to oral tracheally intubate an emergency casualty, right? Your NPA is useless, your King LT is useless, massive facial trauma or burns to the face. Now you're gonna need your cric kit. Okay, we call it cric for short. Next slide, please. You can see here, this person right here, perfect candidate for a cric, right? So, so other than that, this guy's having a bad day here. And other than that, go to the next slide. All right, so right here you can see merits of cricothyroidotomy. Okay, provides a temporary airway for ventilating the patient, can be performed quickly, and has few complications associated with the procedure. This is not a sterile procedure. So, you're going to see it can be, ideally in a perfect world, it would be conducted in a sterile area, surgical room, all that, but in reality, it does not have to be a sterile procedure. You'll see some areas, sometimes they apply some betadine or alcohol to over the cricothyroid membrane, and then they do their process, but it's really not that necessary because it's not a sterile procedure. And we'll get into that here in a little bit as well. Next slide. Okay. Contraindications would be here, like he mentioned earlier, the student in the red shirt. Okay. Basically, yeah, massive trauma to the larynx or cricoid cartilage, then you wouldn't even be able to do that either. At that point, you're looking at different options, a little bit more out of the normal scope of what a trauma medic does in the Army, right? or paramedics would be able to insert a chest tube and things like that. But, other than that, damage to the affected structures will make it, impossible to perform the procedure properly, right? Next slide. Let's see here, we've got, different types of complications. We're talking about certain types of hemorrhages. We talked about bleeding in the lungs, right? And esophageal perforation, subcutaneous, air, you know, that's if you're not placing it the, crike, tube properly, okay? You see some, there's a possibility if you're not doing it correctly, there's a possibility that you could damage that person's, vocal cords, okay? That person, yeah, you could you permanently damage their vocal cords, and if you're not doing the incision correctly with the scalpel, you can cause, you can accidentally, you know, cut that person's carotid artery or the jugular, right? All right? Quick decision, just do it, right? Next slide, recent data. Talks a little bit about the statistics that are done. Next slide. Okay, this is one of the images of placement of a crike tube. As you can see, there must be some type of facial trauma here or some indicator that did not allow for the person to be able to obtain an alternative type of airway, so they have the regular crike kit inserted, right? Next slide. Next slide. Okay, this is a picture of one that was inserted incorrectly, actually. Next slide. Basic anatomy here to determine. We had a PA in our trauma aid stations in the past. He gave us this drawing without any of the 1 through 5 structures indicated on there, and he said, "Who can identify all of these 5 structures?" And if anyone was not able to identify the 5 structures, then that meant that we were not allowed to give a crike to a casualty in the field at any point, because he needed to make sure that we knew what we were doing before we were able to implement a crike in an emergency type scenario, right? So as you can see there, you've got the thyroid cartilage on the top. You've got the cricoid cartilage here. This is your sweet spot right here. The number 3 is where we're gonna wanna go when we do the insertion of the over through the cricothyroid membrane, okay? We've got the epiglottis on number 4, and your vocal cords, right? Which is what you want to avoid at all costs. So you can see, here's your vocal cords, here's a cricothyroid membrane that you need to penetrate to have your tube inserted in a way that you're going to be able to do that here. So everybody look up towards the ceiling. All right. So let's see. All right. So this gentleman right here, you can come up for a second. He's got some good anatomy over here to show you all, you know, where the proper placement of a cricothyroid insertion would be. Okay. So if you look up, you see he's got his Adam's apple right here. All right. You would go right below that, right to about this section right here. And that would be the appropriate incision there for the cricothyroid membrane, okay? I'm actually palpating his carotid arteries right now, so it shows you just how close that is and how careful you have to be. I'm gonna show you exactly how to insert the scalpel so that you don't, can you feel that when I put pressure on your career? So, you know, it's, so other than that, you know, like I said, it's very important to be able to identify. Not everybody will have, you know, a nice size Adam's apple for you to do this, so you're gonna have to be able to palpate and to be able to make sure you identify your appropriate landmark. Okay, next slide. Yeah, because we're running a little short on time, so we're gonna start here on the hands-on here in a little bit. That talks about the site. We showed you already. Next slide. And this is the crike kit. Next slide. Next slide. Next slide. Okay. All right, so we're gonna go ahead and start going into the hands-on portion, all right?